We can start with.
So
Good evening.
yeah, go ahead.
Good evening, everyone. Assalamu alaikum wa rahmatullahi wa barakatuh. We are glad to have you join us this evening for the second and final session of our ECG Interpretation Series. To begin, I would just like Muhammad Farah to lead us in a short opening prayer.
السلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. الرحمن الرحيم مالك يوم الدين. إياك نعبد وإياك نستعين. اهدنا الصراط المستقيم. صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين. آمين.
Thank you, Muhammad. Once again, welcome everyone. This session is organized by the Academics Department of MSAUN KNH in partnership with Peace Medicine. My name is Abdullah Hassan, and I'll be serving as your moderator for tonight's session. Last week, we kicked off this ECG series with an introduction to ECG reading and an overview of some common arrhythmias. If you missed it, the full session is available on our YouTube channel. Tonight, we'll be focusing on a crucial topic, the ST and T-wave abnormalities. Our speaker for this evening will be Dr. Adan AbdiJabar, Senior IMED resident at KNH and founder of Peace Medicine. His engaging teaching style and clinical insights have made this series incredibly impactful, and we're excited to have him back again with us tonight. Let's give him a warm welcome as we begin.
Thank you, Abdullah, for the kind words. Kindly let me know if my screen is visible and if I'm audible.
Yes, Doc, your skin is visible and you're audible.
All right, so guys, as Abdullah has said last time, we went through basics of ECG and we tackled bradyarrhythmias. So tonight we're going to tackle tachyarrhythmias and ST and T-wave abnormalities. These are broad topics on their own. I've tried my best to condense it without making it too complicated for you. So without further ado, these are the objectives. And we'll still look at, for a few seconds, the slide for reporting ECGs. We'll look at tachyarrhythmias, T-wave abnormalities, and ST abnormalities. So as always, this is the objective, to make you a quasi-expert to an expert, a pseudo-expert to an expert in ECGs. So this is how to report the ECGs like we talked about last time. The first thing that you do is to look at the general impression of the ECG. Is this ECG slow or is this ECG fast? Is this ECG ominous? Is this ominous or then the next thing that you move to is the calibration. Calibration, we talked about it extensively last time. It's at the far right end box, it's like the scale of the ECG. And then the next thing that you look at is the rate and rhythm.
Excuse me, Doc. I think you're a bit breaking and we can hear you from very far.
All right, how about now?
Okay, now it's better.
All right, so we also looked at the rhythm and the rate last week, and the ways of calculating the rate and the rhythm. So the other thing that you look at in when you're assessing the ECG is the R wave progression and the axis, which because of the condensed nature of these lectures, I was not able to look at. But generally, that's it. So you look at the general impression, the calibration, rate and rhythm, then R wave progression and the axis. Then the rest is you're looking at the pathologies of the P wave, pathologies of the Q wave. So pathologies of the P wave, whether there's atrial hypertrophy in the P wave, and then pathologies of the QRS is whether there's ventricular hypertrophy, and then pathologies of STT elevation is what we're going to look at today. So the classification of tachyarrhythmias is we divide it broadly into a supraventricular, meaning, and broadly it means anything above the ventricle, but ideally it means anything above the His bundle before it bifurcates. That is supraventricular. And ventricular means anything less below the His bundle, so infrahesia. So anything below the His bundle. So for the tachyarrhythmias, we have the sinus tachycardia, which means it's a normal rhythm, but now it's fast. We have the premature atrial contractions, which are foci in the atria and leads to an impulse. This impulse does not have P waves. Then you have atrial fibrillation, which we'll talk about, and atrial flutter. Those are the two main proponents of the tachyarrhythmias, supraventricular tachyarrhythmias, that we'll delve into. And then there are these other ones which are more complicated, which I will not delve into. So for ventricular tachyarrhythmias, we have the ventricular tach, which can be monomorphic or polymorphic. And then you have the ventricular fibrillation. So we're going to talk about ventricular tach and ventricular fibrillation. So that is the cutoff, the His bundle. Anything above the His bundle is supraventricular tachycardia. Anything below the His bundle is the ventricular tachycardia. So supraventricular tachycardias have several things in common. 100 beats per minute is the heart rate. And so like we talked about the His bundle and above, and then they have this they have narrow QRS, so we call it narrow QRS, narrow supraventricular tachycardias. And then we have wide supraventricular tachycardias. So narrow QRS supraventricular tachycardias are the ones that we've talked about, but in some situations they can be wide QRS when you have aberrancy. And aberrancy means when you have an abnormal conduction pathway, such as Wolff-Parkinson-White syndrome, or when you have a bundle branch block. Bundle branch by its nature is a wide QRS, and then these other ones that retrograde conduction. And you can have a wide QRS supraventricular tachycardia. So, so this is an example. So this is an ECG, it's a 12-lead ECG. You look at it, you see that the general impression is a fast ECG. And you look at the calibration, you see that it's a standard calibration. And you look at the rate, and you look at the rhythm, you see that every P wave. Okay, let me use the highlighter. So it's a fast ECG, okay? And then you look at the standard calibration. Calibration, you say it's standard. And then you look at the rhythm strip. This long strip here is 10 seconds. So you look at the rhythm strip down here, and you have a P wave that is followed by a QRS. So this is a normal sinus rhythm. And then you look at the rate, you say this is 0, then this is 300, this is 150, this is about 120. The other ways of calculating it, but as you grow faster in the learning ECGs, this is how you use and calculating the rate. So that is a supraventricular tachycardia, and this is sinus. So the next thing that we're going to look at is the atrial flutter. The atrial flutter. So the atrial flutter is a type of supraventricular tachycardia that is, the problem in atrial flutter is there is a re-entry pathway. Re-entry means that there is a circular pathway where one side is faster and the other side is slower. So what you have, so this is, let's say, a re-entry pathway, and then you have a slow pathway, okay? So you have a current that is coming through this side, okay? So the current here, initially this is, and it's in the absolute refractory period, and then it goes to the slow part. By the time it's coming back to the fast part, the fast part has already repolarized and is ready to be depolarized again. So you get what is known as a re-entry pathway. So for atrial flutter, it's very specific in that it is what is known as a macro re-entry, where you have a large re-entry as opposed to AFib. So there is a place in the heart here, in the atria. So here is where the tricuspid valve is, and below it is where the inferior vena cava enters. So between the tricuspid valve and the inferior vena cava is a place called the cavo-tricuspid isthmus. That is where the atrial flutter is initiated from. So when it initiates from there, it goes counterclockwise in the normal atrial flutter, and then it causes what is known as a macro reentrant pathway or macro reentrant impulse. So what happens is in the ECG, you get these flutter waves. Flutter waves are sawtooth waves. So these sawtooths can be predominantly up or predominantly down, depending on this clockwise or counterclockwise motion. You don't need to know that. So, but generally, this is atrial flutter, and it has this teeth-like, like a sawtooth appearance. So what this atrial flutter and atrial fibrillation has, they have AV, that the atria are beating on their own and the ventricles are beating on their own. So you have this is the atria contracting, this is the atria contracting, this is the atria contracting, and then you get a ventricular rate. So you have 1, 2, 3. So you have a 3-to-1 ratio atrial flutter, and then the other thing you look at is it's regular. So the difference between atrial flutter and atrial fibrillation is the regularity of the QRS complex. So the ventricles are contracting normally in a regular manner, and the rate is 0, 300, 150, 100, around 75 to 60. That's the ventricular rate. But if you look at the atrial rate, it's about 300. So you have the atria contracting at 300, and then you have the ventricles contracting about 75. So it's dissociated. And then the other thing that happens is that not all atrial flutter will be regular, right? But even when it's irregular, it still has telltale signs that we look at. There is so what is known as irregular. It has what is known as regular irregular, as opposed to atrial fibrillation, which is irregular irregular. So this is what I was talking about. Let me erase this. So you have this this CTI. It's a cavo-tricuspid isthmus somewhere here. Then what it does, it leads to this large reentrant pathway, and then you have this slow pathway, and then the fast pathway, and then leading to flutter and atrial flutter. So this is what I was talking about. Sometimes the atrial flutter will not be regular. I say it will have a block in that there is the variable block in that it stays around. So the AV nodal pathway, some of the impulses will be blocked in a different fashion, and some of them will be blocked in a different fashion. So the first one is a regular atrial flutter. So A is a regular atrial flutter. A is a regular atrial flutter. That means you have 4-to-1, 4-to-1 until the end. B, you have 4-to-1 alternating with 2-to-1, 4-1, 2-to-1, 4-to-1, 2-to-1, 4-to-1, 2-to-1. And then you have C, which is 3-to-1, 5-to-1, 3-to-1, 5-to-1. So you're counting 1, 2, 3, 4, and then there's another one here, 5. So you're counting that, and then 3, 1, 2, 3. So that is 3, and then the 1 here is the QRS. So when you even when you have a variable block, it still has some regularity in terms of the rhythm, as opposed to atrial fibrillation that you will see. So atrial fibrillation, this is atrial fibrillation. You can have fine atrial fibrillation where there is less than 0.1 millimeter from the isoelectric line. That means less than 1 box. So it means like a thread, like, like a thread, like impulses. And then you can have these broad impulses, which can look like atrial flutter, which we'll look at the differences. And so in coarse fibrillatory wave, you have more than 0.1 up to 0.5. That means you have one small box to about 5 boxes in the vertical plane. So this is atrial fibrillation. It's fine atrial fibrillation. It's less than 0.1 above the isoelectric line. So you see this, they're not discernible. They're not discernible P waves. And then the ventricular rate is, this is one rate, this is another 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 rate. So it creates an irregular pattern, as opposed to the flutter that we were talking about. So, and this is coarse atrial fibrillation. And you can see that it has a large fibrillatory wave. And what the differentiating factor is that between coarse atrial fibrillation and flutter is the regularity of the ventricles contracting. So in atrial flutter, you have more of regular, irregular, and then here you have irregular contractions. So same thing here. And you have, if you look at the first one, you have, so you have 2, you have 1, 2, 3, 4, you have 4, then you have 2, then you have 1, 2, 3, 4. So you have 2 to 4, 2 to 1, 4 to 1, 2 to 1, 4 to 1, that is alternating. But here you have no discernible pattern, okay? You can't, so you have 1, 2, 3, 4, 5, 6, 1, 2, 3, 4, 5, 6, 7, 8, 1, 2, 3, 4, 5, 6, 7. So no discernible pattern. And then there is the irregularity of ventricular contractions is irregular. So it has an erratic ventricular rate with no clear pattern. Then this is the fine AFib that we're talking about, where you have, basically it's difficult to delineate the AFib from the electric line. So you have fine atrial fibrillation, and then you have this irregularity in the baseline. And then finally, something that I just wanted to add as in passing is the pre-excitation syndromes. So what we have here is there is a pathway, and then there's the aberrant pathway on this side. So it moves through the AV node, and then it moves through to the aberrant pathway. So this part is generated by the aberrant pathway, and then the rest of the QRS is taken over by the normal pathway because it's faster. So you have the aberrant pathway that causes what is known as the delta wave in Wolff-Parkinson-White syndrome, and then the normal pathway takes over. This is what you have. You have impulses that are coming through the aberrant pathway causing the delta wave, and then you have this the normal now QRS. So what you have is the PR interval is shorter, and then you have a wide QRS. PR interval is shorter, then you have a wide QRS. Okay, PR interval is shorter, then you have a wide QRS. So now we look at the ventricular tachyarrhythmias. And so VT can be sustained or non-sustained. Non-sustained is when it's less than 30 seconds. And then sustained is when it's more than 30 seconds. Okay, or when it's less than, when you have less than 3 beats, and then also when it's sustained, you have more than 3 beats. So the risk of ventricular tachycardias, I wanted to put this slide here, because I know a lot of you probably watch football or watch different games, and you see footballers who collapse in the field. And you see that they are genetic or inheritable diseases that lead to ventricular arrhythmias, okay? So you have this catecholamine polyventricular tachycardia. It works, or it occurs when patients are doing exercise, or when patients are exerting, when they are exertional. So it occurs in the young population, 10 to 20 years. And then you have these long QT syndromes that can occur during swimming or any activity that you're doing, or during sleep. You get someone who just gets ventricular tachycardia, moving to ventricular fibrillation in their sleep. And then you have these Brugada syndromes, which are also bad in their sleep. You'll hear stories of people who got into VTAC while they were sleeping and they were resuscitated. And then you have also this HOCM, hypertrophic cardiomyopathy, where you have in between 30 to 50 years old patients who get these ventricular tachycardias. And then so on and so forth. Generally, I just wanted to put, when you see these things that occur when patients exert themselves and then they get ventricular tachycardias, it's because of these likely ventricular tachycardia syndromes. So the characteristic of ventricular tachycardia, there's so many characteristics, okay? So the one that I wanted you to know is a classic one that people look at is the SLAD S wave. It's also called the Josephson sign. And then you have this Brugada sign where the R starts and the nadir, or the lowest point of the S, it's more than 100 milliseconds, or 2.5 squares. The other ways of knowing it, but that is beyond the scope of this class. It's in the slide, you can access them. But generally, and it's later on, the idea is to see if this patient has true VTAC, or they have what is known as supraventricular tachycardia with aberrancy. But if you're not sure, treat that patient as VTAC. If you're in doubt, manage the patient as ventricular tachycardia, because ventricular tachycardia has more ominous outcomes than supraventricular tachycardia. So these are non-sustained VTAC. So you have 1, 2, 3, and beats 1, 2, 3. Then it stops. All right, 1, 2, 3. Then it stops. So this is a non-sustained VTAC. So the other types of VTACs, so you have a monomorphic, where you have same morphology, monomorphic, and then you have polymorphic, okay, ventricular tachycardia, and then you have a Torsades de Poix, where it's a specific type of polymorphic ventricular tachycardia because of the morphology and because of the way it's treated. So when you have this morphology, so the morphology that you have is twisting of the points. Torsades means twisting, and then points means twisting of the points, okay, or twisting of the end. So you have, and I'll show you later in the other slide. So this is a patient with Torsades. So what you have is, this is what you have. So so you have low amplitude, high amplitude, low amplitude, high amplitude. So this is what is known as twisting of the points around the baseline of the ECG. And you treat these patients initially with magnesium sulfate. And then finally you have ventricular fibrillation, okay? So this, when you have this, then you need to, this patient is really sick and you need to start your ACLS protocol for this patient. All right, so let's move to, and I want to move to, sorry, something I want to move to first. Okay, so we'll come back to the T-wave abnormalities first. So let's go to MI abnormalities. So MI, you know that you can have a complete occlusion where it causes a transmural, meaning the whole epicardium, subendocardium, and the myocardium are affected. And then you can have partial occlusion where you have only subendocardial infarction, where you have only the endocardium that is affected. So we look at the evolution of the ST in a better slide. So you have what is known as injury currents. So the injury currents go towards the area that is injured. So the area that is injured becomes positive compared to the area that is normal. So remember, vectors move from negative to positive. So in subendocardial ischemia, so this is just the endocardium that is affected. So they move towards the endocardium, the vectors. But remember, the recorder, the V5 recorder, is on the surface. So when everything moves towards the interior, then you get an ST depression for subendocardial ischemia. But transmural, everything, the whole wall is affected. So the injury currents move towards the recorder at V5. So you have an ST elevation. So we look at this in more clear slides. The fundamental occlusion principle, this movement that is going on where they want to change the name from STEMI to occlusion myocardial infarction. In the current guidelines of 2025, it was not accepted. But generally, I put this slide because they had good ideas in terms of this. And for you to have STEMI, you need to have this relative elevation. That means that the idea is that you have elevation above the baseline, and then you have this contour. That is in most STEMI patients, you have this contour, and then you have this proportional area where if you are to put this QRS inside this ST, it will comfortably fit. Okay, so those are the principles of an occlusion. So what about localization? Let's start with the slide on the right, the picture on the right, sorry. So on the right, I just put the left-sided blood supply, anterior and left-sided blood supply. So the arteries are the coronary arteries, branches of the aorta. So you have the left main. Okay, left main is up to here. Then it goes to left anterior descending, which supplies the anterior part of the myocardium, including the septum. And then you have the left circumflex. So left circumflex, you can have a high lateral and then lateral. Okay, so you have the left main, which supplies both is divided into left circumflex and left anterior descending. Left anterior descending supplies the anterior and the septal branches all the way to the apex. What about the right side? The right side comes here and supplies the posterior aspect of the heart, and it shares in different populations. It supplies the inferior aspect of the heart in 80% of the population by giving the branch, the PDA branch, the posterior descending artery branch, in 80% of the population comes from the RCA. So that one, we call it a right dominant circulation. And in 10 to 20%, it comes from the left circumflex. When it comes from the left circumflex, we call it a left dominant circulation. And when it's both of them, we call it a co-dominant circulation. In rare cases, you have this left main, okay, going to this LED that will supply everything, apex, inferior, and sometimes going all the way to the back. So that one, we call it a wrap around. It wraps around the heart, a wrap around LED. What about the localization in terms of the ECG? So remember, the V1 and V2 generally are looking at the septum, but there's no clear cut. So we call it septum, and sometimes it can go all the way to the anterior part of the heart. And then you have V3 and V4, which are looking really at the anterior part of the heart. And then you have V5, V6, which are looking at the lateral side. The other areas that look at the other leads that look at the lateral side of the heart are lead 1 and AVL. So lead 1 and AVL are lateral leads, all right? And then you have the inferior leads, which are lead 3, AVF, and lead 2. So you can see here, inferior leads, lead 2, lead 3, and AVF. So that is the inferior leads. And lateral, you have lead 1, AVL, and V5, V6. And then you have the anterior leads, the V1, which is septal, V2, which is both septal and anterior. So that is how you localize this. What about the timelines of STEMI? The the first thing that you get in minutes when you have an occlusion, which is rarely seen, is the hyperacute T waves. Then later on, you get the ST elevation, okay, or ST depression, depending on whether you have it in the anterior part of the heart or posterior part of the heart. Okay. So posterior MI, because the lead is the recorder is in the anterior part of the heart, the posterior MI will be ST depression. So in hours, you can have this T wave inversion, and then finally you will have these pathologic T waves that can persist up to 4 years on. So because the first thing that occurs in STEMI is a hyperacute T wave, instead of looking at ST, we'll start with the T wave abnormality. So the T wave abnormalities are either can be symmetric or asymmetric. So when you have asymmetric T waves, they can be hyperacute T waves that occur in the early part of the MI, or it can be because of hyperkalemia. Okay, so how do you differentiate between hyperacute ischemia or hyperkalemia? Two things really. Is the broad and hyperacute ischemia, hyperacute T waves are broad-based, meaning that they're broad, they're wide in the base, as opposed to hyperkalemia. So usually the T wave is about 4 small boxes. All right. So if you have more than that, then you're thinking of a broad-based T wave. And then the other thing is the top. So you look at, initially you look at the bottom, is it broad? And then you look at the top, is it broad? Okay. So if the top is broad, then that is hyperacute ischemia. Or now for hyperkalemia, the bottom is narrow and the top is pointy. So there is this old adage that people say that if you can sit on it, it's hyperacute ischemia. If you can't sit on it, then it's hyperkalemia. So hyperacute ischemia, because the top is broad, you can sit on it without being pinched. But because of the when you have a tent and you put the stick of the tent there, then you'll have this tented T wave. So the tent, if you look at any tent, they have this pointed part, and then they have this stick. So if you look at this, so as hyperkalemia, you'll have symmetrical T wave. If you put a line at Kati, you have both sides that are symmetrical, and then the top part will be pointed. Okay. So this is hyperacute, and so this is hyperkalemia. But when you have hyperacute T waves, so you'll have a broad base and a broad top, so you can sit on it, but you cannot sit on this one. All right. And then this normal variant occurs in athletes, occurs in normal people, and you have asymmetric, and the top is not narrow. So, Abdullah, is there anyone who wants to try this and tell us what the diagnosis of this case might be, so that we can have an engaging session?
Perhaps if anyone could just kindly unmute and attempt the question.
Maybe I have a few friends I can ask. Sadruddin, do you want to try this one? Oh, there's a hand that is
Yes,
up.
sir.
Okay.
Looking at the ECG, they are fixed T waves, they are symmetric, especially looking at V3, V6, V5, and V4, and they are broad at the base, and they are not as pointy, so they are a little bit flatter at the edge. So I was thinking this could be serious because of myocardial ischemia.
Excellent. So Sadruddin, the other question you ask yourself is, can you sit on it?
Yes, I can sit on it.
So in that case, if you can sit on it, it's a hyperacute T wave, like Sadruddin has said. It's broad base, and it's broad at the base, and it's broad at the apex. So this is a hyperacute T wave. So we move to the next slide. So smooth, broad base. So the other thing we like to call it, we call it ample. Ample meaning big in terms of taller there. Sometimes it's taller than the R wave that is preceding it. Remember the three principles that we looked at for STEMI. So it's taller than the R wave that is preceding it.
Excuse me, though. There was
yeah.
a question, I think referring to the previous question. They're asking if do we check them only in V3 or the other leads too?
Do you check them only in V3 for what? Or for hyperacute or for hyperkalemia?
Yeah.
All right. So, sorry, let me go back. So, the hyperkalemia generally does not localize. It does not go inferior. It does not go anterior wall MI and so on. Okay. So you'll have hyperkalemia in the different, in contiguous leads, all of them, but you will not have localization in terms of blood supply and so on. For hyperacute T waves, you can have early localization in terms of the hyperacute nature, because these hyperacute T waves later on will become an ST elevation. So for hyperkalemia, it might not localize, but remember, you can get hyperkalemia, tall tented T waves in some leads only. You can get it in the anterior leads. So the idea is, the only way to differentiate is to look at the morphology of the T waves rather than the localization of it. So you look at, is it broad-based and broad top? Then that's hyperacute T waves. Is it narrow-based and pointed tip? Then that's hyperkalemia. So you might, and if you get this in exam, you might say, oh, hyperkalemia, it's more diffuse, and then you don't get the answer. But remember that it can as well occur in several leads rather than being diffuse. So the best way to differentiate is to look at the morphology of the T wave. I hope I've answered that. So this is anyone who can. I think the answer has been shown already. So for this, remember, like I said, you might think hyperkalemia is more diffuse than hyperacute T waves. So you already have a narrow base, all right? You have a pointed tip, a narrow base, a pointed tip. So you have it in V2, V3, V4, V5, V6. You have it in AVF, you have it in lead 2, you have it in lead 3. But this is not for every case of hyperkalemia you'll get diffuse. In some cases, you'll only get in specific leads. So that is not the major thing that differentiates hyperkalemia and hyperacute T waves. So there you go, tall tented T waves, hyperkalemia. So hyperkalemia is known as the great imitator. It imitates different conditions. So what happens in hyperkalemia? So we'll start with hypokalemia. You'll get this, and so you'll get these prominent U waves that occur after the T wave, and then you have this biphasic, and biphasic meaning so you have a T wave like that. Initially, it's a depression, and then later on, it's an elevation, and then on top you'll get a U wave, and then the normal And then initially maybe in a case of between, 5 to 6 or 5 to 6 all the way to 7 and peak T waves. And then what happens is as the case increase, the T waves become more broader, and then the PR interval becomes longer because potassium, extracellular potassium, depress depolarization. And because they depress depolarization, you will have less input that is coming from the SA node, but more it affects the atrial muscles more so that you don't have these P waves. So at the end of it, you will have what is known as a sinusoidal wave of hyperkalemia, where you have just sinusoidal meaning you have something like this, okay? No P waves, no QRS. So you'll have sinusoidal in P waves. By the time you reach here, you're having 8 to 9 and potassiums. So you have, look at these T waves, they're tall, tinted, they have sort of a narrow base, but more importantly, they're pointed at the tip. And here, down here, you have this broad and sinusoidal waves. So it's a sinusoid going like this and like this. So you have tall tinted T waves, and then you have this sinusoidal T waves. So it's called a sine wave appearance. So you have poor R wave progression. Most of the R waves are depressed. So you have more of an S wave than R wave in the entire anterior leads. Then you have these bizarre QRS complexes, these sine wave appearances, and then you have the tall peak T waves. So you're having everything that occurs in severe hyperkalemia. And then finally, the other conditions. So you can have hyperkalemia that may mimic ST elevation. This is not your usual ST elevation. It's called a Brugada-like type ST elevation. So you have that. So hyperkalemia can occur and mimic these things, especially in V1 and V2, which already were and already have some level of elevation even in normal individuals, especially in men. Okay, so you have V4, V5, and V6, which have an all tinted T waves, and then you have this Brugada-like syndrome. But anyway, the idea is to show you that, and you don't have to know this Brugada or those things. The idea is to show you that hyperkalemia is a great imitator. Okay. So we're moving towards MIs, and so right now I'll take a break and I'll ask someone to help with this interpretation. So you'll tell us which MI this is and which is the culprit. Anyone from the group, you can unmute yourself and answer so that we have a bit of back and forth in terms of a class that is able to let me look at a lady now. Okay, let me see. Any volunteers? They can't come with anyone on the top of my head. I was going to ask Bridget, but Bridget, you want to try this?
Doc, may I try?
Go ahead.
So we have ST elevation in the V1, V2, mainly V2, V3, V4, and V5. So I would say this is more of an anterior. It's more involving it's an anterior MI. So culprit vessel, we said anterior is more there. I think that it was the left anterior descending, if I'm not wrong. Yes.
What about lead one and AVL?
AVL. Oh yes, there's also elevation in the AVL. So perhaps an anterolateral.
So you have an anterolateral MI that, and you're thinking your culprit vessel is?
Still the left.
I mean, is it?
I think the left anterior descending.
So the left anterior descending LAD occlusion, or sometimes you may have occlusion in the left main. Okay, so you can have that. Excellent answer to that one. And so yeah, basically you have that. So you have anterolateral MI, and and then you have reciprocal changes. In an exam, please always talk about the reciprocal changes. So you have the reciprocal changes in the inferior leads. Remember, reciprocal changes are mirror images of the ST elevation. So the mirror image of lateral wall is the inferior wall, and the mirror image of the anterior wall is the posterior wall. But unfortunately, you don't have a posterior wall lead in the normal ECG. All right. So anterior, posterior, inferior, looking at the lateral. The reason for that is the way the heart sits. The inferior part is looking opposite the lateral part of the heart. What about this one? Any volunteers for this one? Any volunteers? It's a pretty straightforward ECG, really.
I can try.
Go ahead.
So there's ST segment elevation V2, V3, and V4 as well. So this is in keeping with an anterior MI, and I think the vessel affected is your left anterior descending.
Okay, so what about this one? It's not really concave. What about that? V2, V3, they're not concave. What do you think of that? And what about these T waves? What do you think of them? Yeah, you're right. You have the right answer. The only thing is that not all ST elevations are concave. So the concave ST elevation, I mean the convex ST elevation. So convex meaning that ST elevation is called the PADI sign. It only occurs in 40% of patients. So you can have, sometimes you can have the convex. So the only thing that you're looking at mostly is now the ST elevation. Look at the ST, and it has gone above the baseline. So the reason why really changes occur during the T wave area is the T wave represents, after the T wave, or the area about represents when the ventricle, most of it is repolarizing and coming back to the baseline. So you have an area that is repolarizing, right? And then you have an area that has already repolarized. And then when you have an injury, then that current moves towards the area that is injured. So during repolarization, then you have this ST elevation in that area. So despite there not being concavity, there is hyperacute T waves here, and then there is the ST elevation, which points towards an MI. Okay, what about this? Anyone can try this? Anyone
I
who
can
can try
try
this?
that one.
The ladies are okay. Right.
I'm seeing ST elevation in leads 2, 3, and AVF. And we also have reciprocal changes in AVL. Okay, suggestive of an inferior wall MI.
The culprit.
The right coronary artery.
Excellent. Why? Why not the left circumflex?
Because like 80% of the patients have like a right dominant circulation.
Yeah, but what if this patient is in the 20%? So
Okay.
it's a good. So it's an RCA, and it's an inferior wall MI. Excellent. So when you're looking at to differentiate between LCX and LCX and RCA, you look at the mirror leads. So the mirror leads for inferior MI. So you have this RCA. So RCA is more towards the lateral, and then you have AVL here and lead one. So RCA, the mirror images are lead one, so AVL, sorry, and lead one, as opposed to circumflex, which is usually at the middle. So circumflex, you have just the lead one that is depressed, as opposed to RCA, where you have both AVL and lead one that are depressed. So this is important in that later on we become cardiologists and you see this ECG, you know that this is RV wall MI, which is treated differently as other MIs. You try to restrict fluid management, and when you're intubating, you try to be careful with that. There's some drugs you not give in right ventricular wall MI and so on. So, and when you're doing catheterization, you know where to go to in terms of management. All right, so inferior wall MI. So inferior wall MI can be left circumflex or a right coronary. The culprit vessel is the right coronary in this case because the mirror image and AVL. So this one, if you look at it, is you only have mirror images. So you have lead 2, lead 3, AVF, inferior MI. So you have only mirror image in the AVL, but lead 1 is normal. So in that case, you only have left circumflex and all MI. What about, so now we're moving on from STEMI, we move on to ST depression. So you have what is known as, ST depression can be 3 things generally. It can be subendocardial ischemia, or it can be other causes of diffuse ST depression. So when you have ST depression that has occurred because of subendocardial ischemia, so ST depression due to subendocardial ischemia does not localize, it's diffuse. So it does not point to one side, it's diffuse generally. So when you get this diffuse ST depression everywhere, then you're thinking either diffuse, you're thinking subendocardial ischemia because of either severe coronary disease, where you have either left main proximal LAD or severe 2 or 3 vessel disease, or you're thinking about patients who are generally unwell because of other things, such as, profound shock, GI bleeding, and so on. So subendocardial ischemia generally does not localize. Diffuse ST depression generally does not localize. So you have these two things, and in clinical practice, it's important to do the troponins to see how the troponins are so that you make quick judgment in terms of these patients. So what about posterior MI? Posterior MI, in patients with posterior MI, you have depression in the anterior leads, especially V2, V3, and V4. And the depression generally is horizontal as opposed to upsloping. It can have upsloping, but generally you have horizontal depression. So that if you are to turn this ECG upside down, you have a STEMI. Okay. If you are to rotate this ECG upside down, you'll have a STEMI, and you'll have an ST elevation in this case. And then the mirror image of this, of course, and you're looking at the mirror image because this is posterior MI. If you are to have leads in the posterior, in the scapula, it will have been ST elevation. But now you have mirror image in the anterior leads, and that's why you're having ST depression. So the ST depression for the posterior MI localizes to the anterior leads, as opposed to subendocardial ischemia, which is generalized. All right. So who can tackle this question? Any volunteers? We've had ladies who volunteered. Any gentleman who will volunteer?
I can try if there's no gentleman.
Go ahead.
Okay, so this ST elevation, which is okay on the V2, V3, V4, 5, and also on 2, 3. I would say there's like a diffuse ST elevation.
Excellent. There's diffuse ST elevation. So what does that mean? Which is the culprit vessel?
Mm-hmm. That one you can help me.
So thank you, Doc. That's excellent. So
Usually I think usually
Pericarditis.
pericarditis. So like I don't know if like what specific vessel is going to be affected in pericarditis.
So this could be pericarditis, okay?
Mm-hmm. Yeah.
Because of the ST depression in there. So you have ST depression here, okay, and then you have ST elevation. And so PR depression here, and then you have ST elevation, okay. And if you look at the AVR, you have PR elevation, and then you have ST depression. But there is a scenario where this can be MI. And the reason why I'm looking at MI is I'm looking at this broad broad T waves. If you look at these broad T waves, broad ST waves, okay? There is a scenario. There are two scenarios where you can have this, but the most common scenario, especially if it's a myocardial infarction, is if you have, sorry, let me come to this. So if you have, okay, I was looking for the slide of all right. So if you have what is known as a wraparound LAD, an LAD that supplies the anterior wall, that supplies the posterior wall, that supplies the inferior wall. So what's a wraparound LAD? So normally, the LAD comes all the way, goes a bit to the apex, then the rest, the inferior wall is supplied by the LCX, then posterior wall is supplied by the RCA. But this wraparound LED, if you have a proximal occlusion of it, then you can get a wraparound blockage, a wraparound LED that is blocked. So it will affect the anterior wall, it will affect the inferior wall and some part of the posterior wall. But it's a bit difficult to differentiate between acute pericarditis and a wraparound LAD. So in that cases, you can look at signs and symptoms of this patient and the troponin rise or the troponin fall in these patients. So remember, before you just say that this patient has acute pericarditis, especially in an older gentleman, then also remember that there's this condition that is known as a wraparound LAD, especially if they have risk factors, dyslipidemia, hypertension, and DM, as opposed to a young guy, 15-year-old to 20-year-olds who will have these changes. You'll think now it's likely acute pericarditis. Okay, so this STEMI occurs in other conditions, such as when you have changes already in the QRS, such as when you have an RBB or LBB. So in RBB, when you have STEMI, what happens is that you have RBB, you have the rabbit ear. Okay, so these are two ears. So when you have RBB, that is a right bundle branch block, you have the disappearance of the first ear. So you get something like this instead of the rabbit ear. This is generally just to tell you that is possible. It's likely beyond the scope of this class. What about when you have LBB? So when you have LBB, you used what is known as the Gabosa criteria. Is an Argentinian cardiologist. So you look at when you have a discordant RS, that means the R is pointing upwards and you have the S that is pointing below. Then if you get an ST wave elevation of 1 millimeter, then that is likely to be a patient with MI. And when you have a concordant and LBB, where you have the R and the S are pointing at the same side, then you need 1 millimeter and ST elevation in a concordant LBB. And then when you have the ST elevation in patients who have discordant RS, then you need about more than 5 millimeters. So that is generally it. So when you have a new LBB, always think of the patient maybe the patient may be having an MI. So then you can go and check whether you have your troponins rise and fall in such patients. So this is also sometimes you go with the mindset I'm either getting a STEMI or I'm getting hyperkalemia. Then you get this, and you don't know where to start. You're looking at this ECG, you think, okay, it's atrial tachycardia, but I don't see anything else. But generally, the question might be pointing towards a patient. So 30-year-old female, DM hypertension in puparium. So puparium is a hypercoagulable state. But our department is sometimes they can give you a male patient. So remember always that patients with PE, remember always the S1, okay, Q3, T3. So that occurs in few % of patients, but it's a classic finding. So if you get S1, Q3, and T3 is a patient with PE. But there are more frequent signs of PE, such as, you know, and other patterns, such as the most common pattern in patients with PE is a patient with tachycardia. Other patterns in patients with PE is RBB, that is right bundle branch block. Then you have this because the right side of the heart is under strain, you have the right axis deviation, and then you have this R wave, poor R wave progression. So instead of a biphasic R wave, the biphasic R wave can go to all the way to V4 or to V5. So that's it for this session of tachyarrhythmias and LBB and STT wave elevation. We're open to questions right now.
If anybody has any questions or you need any clarification, please just feel free to unmute or write in the chat box.
I have a question.
Yes, Jabar, you can go ahead.
In the scenario whereby you don't have, let's say, S1, Q3, T3, or let's say even this ECG here, when you're looking for right ventricular strain, could you also say that there's ST depression and T wave inversion in V1 to V3?
Yes, so that is not. Yeah, go ahead.
No, I'm done with my question.
So that is what is known also as a strain. Okay, so you have the RV that is strain, is under strain. So T wave inversions and can signal a patient who has an RV strain pattern. Okay, so that is also T wave inversions can also be one of the one of the findings in ECG of patients with PE. But remember, T wave inversions can also be early signs of patients who have an MI, a special type of MI that is known as a Wellens. So Wellens is a STEMI mimic, which I thought it was beyond the scope of this class. So there are things called STEMI mimics. So RV strain pattern is possible in terms of this.
Okay. Thank you.
I see a question that was asked on re-explaining the reciprocal and mirror leads again, the concepts.
Oh, okay. I need to go back to the heart. So that I show a visual of what. All right, so when you have, so let's start with anterior. So when you have anterior wall MI, the anterior wall is looking at the posterior wall. Okay, so the changes, if you are to have other leads in the back of the scapula, if this was a ST elevation, this will have been a ST depression, and vice versa. So because we don't have leads that are in the back in the scapula around the area, so what happens is that we use the anterior leads if they have ST depression, and the way I explained it, ST depression that is horizontal, and then we're thinking that maybe we're having posterior wall MI in such patients. And then the lateral wall is opposite the inferior wall. So if you have an inferior wall MI, then reciprocal changes will occur in the lateral wall. And if you're having a lateral wall MI, reciprocal changes will occur in the inferior wall. It's just the way the heart is sitting in the thorax, in the thoracic cavity. So that's how the changes, the mirror changes occur. So if I have a lateral STEMI, lateral wall STEMI, then I'm looking at the inferior wall for ST depression. And if I have an inferior wall STEMI, I'm looking at the lateral wall for ST depression. And then anterior, the only way to check whether the reciprocal changes for an anterior wall MI is if you look at, leads in the scapula. But if you get ST depression that is localized, okay, that is horizontal and localized to the anterior leads, and this patient has signs and symptoms of acute coronary syndrome, think about posterior wall MI. I hope that is clear.
I also see another question. Somebody asking, how do you recognize the rate of sinus tachycardia? Rate.
Rate of sinus tachycardia is, since it's a sinus rhythm, you'll use the normal rate. So the normal rate in that you're looking at sinus tachycardia means that the impulse is coming from the SA node. The only reason for the tachycardia is because of a sympathetic overdrive. So you're using the normal way of calculating rate and rhythm, in that you're calculating the difference, the distance between the R waves, and you're calculating the number of big boxes or small boxes depending on the style that you use to calculate the rate. So sinus tachycardia is a normal ECG. The only problem is the sympathetic overdrive that has led to a faster ECG, such as when you're doing exercise, or immediately after exercise. Even if a ECG is taken, you'll have sinus tachycardia, or when you have fever, physiological.
We don't see any other question.
And so on, so as opposed to flat.
Let's look.
Hello, I have a question.
Yeah.
Yeah, maybe a clarification about STEMI. I want you to clarify for me about the contiguous lead, because there's somewhere, I think I read that you have to get it in at least 2 contiguous leads. Like maybe you can give us an example and then you clarify about the contiguous leads.
Thank you. So contiguous leads do not mean, so contiguous leads are 2 leads which are anatomically next to each other. So they don't mean, that, like, they don't mean that they should be close together in the chest, physically when you're putting the leads. So it means this concept of AVL and AVL and lead 1 are contiguous leads, but they're not together in terms of when you're putting the leads. And lead 2, AVF are, okay, they're close together, but those are the contiguous leads. They're pointing towards a location of blood supply. So contiguous leads are leads that are looking at the location of blood supply, rather than, when you're putting the leads in a patient. So that is contiguous leads, all right? So the definition of MI is a patient with signs and symptoms of MI and ST elevation of more than 2 millimeters in men and 1.5 millimeters in females, okay, in 2 contiguous leads. These contiguous leads, so these 2 and 1.5 are in V2 and V3, the V1, V2, V3, because in some normal men, especially those in healthy male patients, especially less than less than 40 years old already have some degree of ST elevation in V1, V2. That's why the cutoff is higher in male patients than female patients. So it means that if you get a female patient who already has an ST elevation of above 1.5 in V1, V2, it's not normal. That patient has an MI, even if she's 30 years old, as long as she has signs and symptoms of ACS and she has 1.5, that means a small box and a half in V1, V2, V3. But if you have a male patient who is less than 40, which the cutoff is 2.5, that means half of the entire, big box, then that patient is now you're thinking of is an MI. But if he has 1 millimeter, does not have signs and symptoms in OPD somewhere, then that's a normal variant for male patient. So in terms of contiguous leads is what I talked about. These are leads in terms of the blood supply they're together, such as the lateral leads, lead 1 and AVL are together, and then the inferior leads, lead 2 and lead 3, AVF are together. Those are contiguous leads. And then you have the anterior leads, which are contiguous in terms of how they are. And then you have V1, V2, which are contiguous for septal, but V2 is also, there's an overlap for anterior as well.
Doctor, a follow-up on the same. Is the elevation different for the limb leads? You see how you said the anterior leads, or rather the V1, V2, you have to have an elevation of about 1.5 to 2.5 millimeters. Does the same apply to the limb leads?
So the limb leads are different. The limb leads is 1.5 for everyone. And so these differences in male and female are only in the V1, V2, V3. In the limb leads, and then in the lateral leads of the anterior chest, then the difference is 1.5. So you're looking at 1.5 elevation in the different, especially in the limb leads, you're looking at 1.5 elevation. Is that is that okay?
I see we can take just last 2 questions that I see in the chat box. The first asking, how do we define a ventricular hypertrophy in ECG? And the second question being, clarifying the concept of the concave and convex STEMI morphology.
All right, so the first one it wasn't.
How do we define a ventricular hypertrophy in ECG?
So if I were to go to that, it will have gone longer. So right ventricular hypertrophy, you're looking at V1, V2. Instead of having a predominant S wave in V1 and V2, you have a predominant R wave. So that points towards a right ventricular hypertrophy. All right. And then for LVH, so that one was RVH. For LVH, you use what is known as the Sokolov criteria. So Sokolov criteria is the highest elevation R wave in V4, V5, V6, and the highest ST depression in V1 should be more than 45 millimeters. So that means that you have 9 big boxes together in V5, V6 plus V1. The other criteria, but generally that's what you use in terms of LVH and RVH. The other question was?
The other question was just re-explaining the concave and convex STEMI morphology.
So I don't know that we need to go back to. Yeah, I think it's not that far. So the contour is what we're talking about. So the contour of STEMI is convex in that it's convex this way. So this occurs in about 40% of patients. That's how smooth the contour of the ST elevation is. But sometimes you can have a concave morphology. So don't dismiss a concave morphology. And a lot of us look at convex and dismiss the concave morphology. So the convex occurs in about 40%. It's called the PADI sign of patients. Okay. All right. Anything else?
I think that will be all for the questions. Alhamdulillah, that brings us to the end of our two-part ECG series. Thank you, Dr. Adan, for guiding us through these sessions. We truly appreciate your time, effort, and dedication. To everyone who joined us, thank you for tuning in and being part of this learning experience. We hope you walk
Abdullah,
away with... Yes, Doc.
Can we answer these questions on the poll, and we can go directly and see if there's no other class we can go and check how these ECGs are. Is that okay?
Yeah, that's okay. So you would like to go to the Twitter page itself, or?
Yeah, and the Twitter page itself, and we see how the questions
being answered.
What the issues, yes, and we see how individuals are answering the question. Guys, kindly, these are patients that we had, so live patients. Tell me what you think of this ECG, and what is your answer, and then we'll answer live. So a 25-year-old patient with history of palpitations. She has a palpable P2, wide split S2, and a systolic murmur in the second ICS. So this ECG was done. What do you think of this ECG? What rhythm do you have? Kindly vote. So there are two answers. So there's coast AFib, there's regular atrial flutter, and then there is atrial flutter with block. And then you have, what is the diagnosis? You have ASD, atrial flutter with pulmonary hypertension, or VSD, atrial flutter with pulmonary hypertension. So I can see already there are about 5 votes. Come on, guys. We can have more votes than that. And then we'll answer this. Just go ahead and vote for whichever thing. Just look at the ECG. So the first thing you're looking at in this ECG is it a narrow QRS tachycardia? Yes, it's a narrow QRS tachycardia. That means it's a supraventricular tachycardia. So the next thing you're looking at is it regular or irregular? What do you guys think? Is it regular or irregular? That is the clue to the answer. All right. What do you think? We have about 5 votes so far. Okay. Anyway, so if you look at this ECG,
Doc, would you like me to share the question from my side or your side? Oh, it's okay.
Oh, it's not being shown? Is it visible?
Like from your side, Amma?
From my side, is it visible?
No, from your side, I'm still seeing your previous slides. So
okay.
maybe
You can share.
Just stop share.
Yeah, go ahead. Yes, it's visible.
Yes. So this was the question, right?
Yes, that's the question. So what do you guys think of the question? The options are there in terms of...
Doc, did you ask what you think about the question, or what was the question?
The diagnosis. What is the diagnosis?
Is it an ASD?
Yes, the diagnosis is an ASD with pulmonary hypertension because of the systolic murmur in the second ICS and a palpable P2. But what about the ECG diagnosis?
You asked us if it was regular or irregular. I'm tempted to say regular.
Yes.
It's regularly irregular.
Yes.
So
What
you
about
told us, and you
it's
mentioned in the previous slide, teaching, that's how you differentiate AFib and F latter.
yes. So it is actually regular, and if you look at the fibrillatory waves, the flutter waves, sorry, you have 1 2 1 2 1 2 1 2, all that, and then the rate, the ventricular rate is the same. So you have 2 to 1 2 to 1 2 to 1 2 to 1. So the difference is sometimes when you have a close AFib vis-a-vis an atrial flutter, someone might be confused about it. So this is an atrial flutter because of the regularity of it, okay? And this patient had, it's a real patient, so this patient had ASD, wide ASD at 25 years old. And the only thing that she presented with was palpitations. And when we did the ECG, this is what it showed, these flutter waves. All right, so that's it generally. And there's another question I put about MIs. Kindly attempt and also kindly follow us. And thank you, Doc, for the great answer. So this is an ASD case. ASD patients present this way, and they have palpitations. So this patient had right ventricular failure, and because she developed dyspnea and right ventricular failure, and then she had this atrial flutter. And there's another question about MIs. You can answer that, and then we will give feedback on the questions, especially the one that is left after the poll ends. So from my side, thank you so much, guys. All the best in your interpretation of ECGs. It's really simple, so it just requires practice. With practice, you will eyeball an ECG and know that this is the diagnosis of the ECG, and you will not labor with the ECG. The exam favorites for ECG are hyperkalemia and hyperacute T waves and PEs. So you look at those as many times as you can. And I'd like to thank the team from MSAUN for inviting me to do this, and all of you for giving your time to come and listen to this session. Abdullah,
for really empowering us with a lot of ECG interpretation knowledge. We definitely do not take it for granted. I believe the 6th years who are also going for the exam soon are definitely grateful for your time and for your session, for this session. Thank you everybody for attending. On behalf of MSAUN KNH Academics team, we wish you all the best in your academic and clinical journey. السلام عليكم ورحمة الله وبركاته. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك.